Your billing team is verifying insurance. They are submitting clean claims. They are following the playbook. But if the money is sitting in accounts receivable, it stops hitting the bank. A pending prior authorization is a revenue leak. While a claim waits for approval, the clock on timely filing limits continues to tick, and the cash your practice has earned remains trapped. The problem is not your staff. It is the environment they work in. Payer algorithms are tightening, denial rates are rising, and authorization rules are multiplying. Tracking these statuses requires a level of daily attention that most in-house teams lack the bandwidth to provide. Stalled claims are a byproduct of a system designed by payers to slow disbursements. Defeating that system requires a specialized operational approach. Data from the American Medical Association shows that physicians and their teams spend 13 full hours per week on prior authorizations. That is 13 hours per physician dedicated to a task that generates no clinical value. Payer AI is accelerating this burden. 61% of physicians report that automated payer decisions are driving up denials, pushing the national average to between 10 and 15%. Relying on in-house generalists creates a cycle of instability. The fully loaded cost for one internal specialist reaches $75,000, but the real cost is the 40% turnover rate. Every time a staff member leaves, the practice loses up to $30,000 in recruiting and productivity gaps. When that specialist leaves, they take their institutional memory with them, the specific payer portal quirks and the history of your most difficult accounts. While the practice hires and trains a replacement, the unworked claims age into the critical over 50-day zone. When training costs and turnover rates outpace the speed of reimbursement, generalist teams cannot stabilize the bottom line. To maintain an AR cycle under 35 days, top-performing practices are moving away from the in-house staffing model for authorization follow-ups. Reading complex explanations of benefits and challenging medical necessity denials requires technical expertise. This is why specialized practices use experts credentialed by the AAPC and AHIMA who understand CPT codes and modifiers at a granular level. Instead of generic call centers, these practices use embedded specialists. These experts log directly into the practice's EMR, whether it's Epic, Athena, or NextGen, to work as a dedicated extension of the local team. This model relies on a strict compliance framework. Specialists work from biometric secure facilities that meet HIPAA, SOC 2 Type 2, and HITRUST standards. This ensures the outsourcing functions as a secure extension of the practice's own data infrastructure, maintaining existing workflows while increasing technical depth. Implementation is built for speed. Portal access is typically established within 48 hours, and the team begins working accounts inside the practice's EMR within 14 days. While internal teams often check statuses weekly, embedded specialists perform follow-ups daily. This frequency is necessary to catch payer decisions early and prevent claims from stagnating. To counter payer algorithms, these teams use provider-side AI to manage the workflow. This pipeline illustrates how requests are managed. Smart routing and predictive analytics scan the accounts, color-coding them by risk and urgency. High-risk accounts are automatically flagged for specialist intervention before they age into denials. Combining predictive flagging with credentialed human review provides a reliable method for managing automated payer denials. Days in accounts receivable is the primary indicator of revenue cycle health. Any performance over 50 days signals a significant cash flow concern. Specialized RCM support changes the math. FHMA benchmarks show that switching to this model strips an average of 12 to 18 days out of the AR cycle, moving a practice from a cash flow crisis to a healthy performance range. The economic difference is direct. An in-house salary costs $55,000 to $75,000 per year, plus the cost of turnover. A dedicated Staffingly seat is $399 per week, or roughly $20,700 annually. This model also addresses the lack of visibility in many billing departments. Weekly KPI dashboards give CFOs and COOs the data they need to track throughput and accuracy in real time. Beyond the $50,000 saved in overhead per position, this process forces tens of thousands of dollars in previously trapped cash flow into the bank every month. Protecting revenue in the current landscape is about consistency. Success requires a data-driven, daily process handled by credentialed experts. Staffingly offers a 14-day risk-free pilot. This allows practice leaders to verify the results inside their own EMR without a long-term contract. For a practice sitting above 40 days in AR, addressing authorization follow-up is the most immediate way to stabilize cash flow. Top-performing practices do not simply add more staff to the problem, they upgrade the architecture of the revenue engine itself.